This is Dr. Frank with Stanford School of Regional Anesthesia. Recently, there's been a lot of talk about using different thoracic wall blocks. The most prominent of them is perivertebral block. We perform perivertebral block. We have some educational videos on this website. However, there's some untoward complication of this block, and recently there are some new blocks being introduced for the chest wall. The novel block that comes to us from Spain is the PECS 1 and PECS 2 block. These blocks are performed for breast operations. Usually PECS 1 block is used for subpectoral prosthesis or for implant placement. Sometimes it's used for analgesia during AICD or pacemaker placements. The anatomy of it, that you perform this block between the PEC major and PEC minor muscles. You inject lateral to the pectoral branch of thoracoacromial artery. In that location, lateral pectoral nerves pierce through the fascia, and lateral pectoral nerve innervates the lateral portion of the chest. The positioning of the ultrasound would be the same as the as infraclavicular block, and we will show it to you shortly. However, what we have found that this block by itself is not sufficient enough to cover the entire chest wall. So as our colleagues from Spain described, there is a modification called PECS 2 block that we've been using with better success, and that would be our a block of choice for anesthetizing axillary lymph node dissection or complete axillary resection together with a mastectomy for breast cancer operation. That block is performed in conjunction with modified PECS 1. We do it through one injection, and with very good results. We've been doing it for over a year, and here's how we do it. When performing this block, we position the patient the same way we would position them for an infraclavicular block, which means the patient is supine with me standing at the head of the patient, and the ultrasound is on the side being blocked. In this particular case, we're going to perform a block on the right side, so the ultrasound machine is on the right hand side. I'm going to position the patient's position supine with the head turned away from the ultrasound machine and ultrasound probe, and then I adduct the arm 90 degrees. When the arm is adducted, I'm going to place the ultrasound probe in the pectoral clavicular fossa, and right near the coracoid process, which is pretty much the same way I would position it for an infraclavicular block. As you can see on the screen, you recognize the structures of PEC major, PEC minor, artery, and a vein. Now, in order for me to get the desired view, what I would do, I would tilt the probe so that the beam is facing medially, like so. And as I do this, you'll be able to see a rib on the screen. This is the second rib. What I'm going to do, I'm going to slide my probe quadad and laterally, counting the ribs down. This is the second rib, third rib, fourth rib. Fourth rib is my target. This is the fourth rib, third rib. There's a pleura, intercostal muscle, serratus anterior, PEC major, and PEC minor. The needle path goes from superior to inferior. On the screen is going to be right to left, inferior is to the left, superior is to the right, and the needle path is going to be through the PEC major and PEC minor, and my target is I'm going to put it on top of the fourth rib. This way it provides an extra safety, thus decreasing the risk of pneumothorax, and I will deposit the local right here on top of the fourth rib. There is a big debate in the literature whether or not to deposit the local anesthetic below or above the fascia of serratus anterior. We don't know the answer to that, so we usually just deposit it to make sure that the local anesthetic spreads in the plane. I would say most of the time it winds up being under the plane, and we deposit about 20 cc's of local anesthetic there, and then as we withdraw the needle, we deposit another 10 cc's under the fascia between PEC major and PEC minor right here. And that's how we do a PECS 2 block.
Dr. Stephen Finkel from the Stanford School of Regional Anesthesia. This view, which should look familiar after Dr. Frank's demonstration, shows a typical PECS view. Right side of the screen is cephalad, left side is caudad. The needle will be approaching from right to left across your screen, first traversing the pectoralis major muscle over the top of the third rib, heading toward its target, which is the fourth rib. It's very important to keep your needle in view so that you do not head toward the pleura and give the patient a pneumothorax. Now you can see the injectate has begun as the needle is sitting on the top of the fourth rib. We typically inject roughly 20 cc's of local anesthetic underneath the serratus muscle on top of the fourth rib. You note the local anesthetic spreading here. Once this has been achieved, we then will slowly remove the needle, heading back toward the pectoralis major and minor muscles, where we will inject another 10 cc's of local anesthetic in that plane in between the two muscle groups. You can see that happening now. The needle is now sitting just about in the right position, and the injectate will begin momentarily. Once this has happened, we have now injected in the two locations necessary to obtain PECS 1 and PECS 2 blocks. This should result in effective anesthesia for the chest wall and axilla.